This is Soundcheck, your go-to podcast for ultrasound quality assurance, image review, and clinical education from MedStar emergency physicians. We walk through real cases, highlight what to look for, and dig into how ultrasound guides decision-making. Here's your host, Dr. Jon Watson.
Hey everyone, welcome to the December 2025 episode of Soundcheck. We've got a really great lineup of cases for you this month. We're starting off with a first-trimester pregnancy scan that really highlights why switching from transabdominal to transvaginal ultrasound can make all the difference. Then we'll move into a high acuity case, syncope, abdominal pain, and a ruptured ectopic pregnancy diagnosed right on the FAST exam. After that, we'll review classic findings in acute cholecystitis, take a look at a dissection flap caught on bedside aorta ultrasound, and finish with some striking images of polycystic kidney disease from a patient who came in with severe hypertension. And make sure to stick around for our listener Q&A at the end. Dr. Yasmina Abdous is going to join me to walk through a step-by-step approach to ultrasound-guided IVs. It's one of the most practical tutorials we've done so far, so don't miss it. As always, I'm joined by some excellent co-hosts, and we have a special treat this month. We have two co-hosts. We have Dr. Emma Love, who is a first-year emergency medicine resident at Georgetown Washington Hospital Center Emergency Medicine Program, and Amelia Kogan, a future emergency medicine physician who is applying now for residency and was joining us for an ultrasound elective. So let's go ahead and bring in our co-hosts now, Dr. Emma Love and Amelia Kogan. Amelia and Emma, thanks for being here.
So good to be here. Thanks for having me.
This first case is a young woman who came to the ER with vaginal bleeding in early pregnancy. She had a positive pregnancy test at home and said that her last menstrual cycle was about 6 weeks ago. Emma, can you walk us through here what you're seeing, what sort of study they're doing?
Yeah, so it looks like here they're doing a abdominal ultrasound. Kind of see them starting through here. We have the uterus, and then we see the bladder there. Mm-hmm. In the uterus there, you see a sac of some sorts. It's not super well visualized.
Yeah. So there's something there probably in the uterus, but not really that well seen at this view. So let's go through a couple other images. Now they're transitioning to longitudinal view. So how do you get from that transverse view to longitudinal axis with your probe?
You'll just rotate your probe 90 degrees. Probe marker facing up.
Right, towards the patient's head. Perfect. So then they're fanning side to side and seeing more or less the same thing, right? Kind of hypoechoic sac there, but any other features that, are you convinced this is a intrauterine pregnancy?
No, I mean, it certainly could be, but it's not definitive at this point.
Yeah, so it could be early pregnancy, but kind of pregnancy of unknown location, threatened miscarriage, or completed miscarriage, or ectopic pregnancies, of course, all still in the differential. So I think we need to get a little bit more information. So Amelia, what are they looking at here?
We are looking at the right adnexa.
Mm-hmm. So why would you look for through the adnexa in this scenario?
Well, we want to make sure that we can rule out an ectopic pregnancy, see if there's any fluid around the adnexa. Right.
Yep. So are you seeing any sort of abnormal mass or anything within the right adnexa?
Not that I can see.
Yeah. Free fluid would be suspicious as well, but we're not really seeing that. And then they're going to move over to the left adnexa as well. Scanning through, we see some pelvic vessels, circular here, some loops of bowel in and out, but no, nothing like that's very obvious or concerning right now. So in order to get better views, Emma, what would you do next if you're not really convinced by the transabdominal ultrasound?
Yeah, I'd go to a transvaginal ultrasound.
Yep, perfect. So let's go to transvaginal. So now we're using the endocavitary probe, right? Because we can tell the change not just by the picture getting a lot better, but by the footprint here. So we're in sagittal view, meaning that the probe indicator is pointed up towards the ceiling, and they're fanning left to right on the patient's body, getting that sagittal view like you would on a CAT scan. And kind of walk us through what you're seeing here.
Yeah, so as you mentioned, we're seeing the uterus here, and you can see kind of that hypoechoic structure we saw in the other view, but this time you can actually see the yolk sac within that fluid cavity.
Yeah.
It looks like a little Cheerio. You can see that kind of popping up.
Perfect, yep. So the yolk sac is present. Let's freeze it right there. So we see that little, people call it a Cheerio. within the uterus. So this basically confirms that you have intrauterine pregnancy at this point, right?
Yes, it does.
Good. So let's keep going through. These are really good quality images, I think. And it was a good job for the sonographer to go to transvaginal ultrasound as well. So here, just for teaching, we have the uterus kind of outlined here, all the way down, the cervix in this area right here. And IUP now within the uterus. So let's go through the sagittal view again, another view, seeing that yolk sac. Good. And then Amelia, what do you see here? What are they trying to demonstrate?
They're looking at fetal cardiac activity here.
Yep. So we can see where the fetus is here. It's very, very small, but this is the fetal pole right on this area. So this is the yolk sac, and then the fetal pole on one end of it sort of has that appearance. They call it kind of looks like a diamond ring almost, right? And you see that little fluttering inside of it. So that's fetal heart tones. I'll say in this case, they weren't able to get like a M mode tracing of the fetal heart rate just because I think it was too small or just too difficult to capture. But in that scenario, you can just take a video clip like they've done just to demonstrate fetal cardiac activity. So Amelia, what are they showing in this still image here?
So they are measuring the crown to rump length. So you can see it measures about 0.23 centimeters, which puts us at about a 5-week, 5-day pregnancy.
Yep, good. And that's pretty consistent with the dates she told us, right? With last menstrual cycle being about 6 weeks ago. And just note that they are measuring this correctly. They did a good job of excluding the yolk sac. I've seen a lot of times they include the yolk sac. It's going to give you way different measurements, but you just want to include just this fetal pole area here. Great job. So then we're going to switch to a coronal view. So in order to get this, how do you go from sagittal to coronal, Emma?
For sagittal, your probe indicator is facing up. For this one, you're just going to rotate your hand 90 degrees so the probe indicator is pointing towards the patient's right.
Correct. Perfect. And then they're scanning, moving their hand up towards the ceiling and then down towards the floor to scan through the whole uterus. And we're again demonstrating that fetal pole on that yolk sac there. And then we can see some views of that adnexa. We see a lot more clearly this time, right? We couldn't really see the ovaries or anything during the last transabdominal view. But now at the beginning of this clip, we can see the ovary here. Okay, what snack does that remind you of?
Looks like a good chocolate chip cookie to
Yeah,
me.
not to me, but that's what people say. Yeah. So yes, so it kind of has that chocolate chip appearance, and the anechoic areas within that are because of the follicles, right? And that's what gives it the chocolate chip appearance. And then we go through the left adnexa too. And we see at the beginning, very beginning of the clip, we can see the left ovary, which looks normal. So overall, I think this is a great pregnancy scan. Great job for the sonographers from switching from transabdominal to transvaginal, demonstrating an IUP. But we just want to counsel the patient. Emergency ultrasound is generally for limited indications, right? We're just confirming IUP, and by way of doing that, basically excluding ectopic pregnancy. In the setting of vaginal bleeding, it still could be a threatened miscarriage. So you don't want to give too much reassurance and say that everything's completely normal with the pregnancy, but right now, a lot of the emergent conditions have been ruled out related to pregnancy. All right, so this next case was a young woman who came in with pretty severe abdominal pain and had an episode of syncope at home. In her history, they had noted that her last menstrual cycle was about 23 days prior to arrival, and she was hypotensive, so they initiated a FAST exam on this patient. Amelia, what area are they looking at right now on the FAST?
So we're not entirely sure. It appears to be the left upper quadrant. It looks like we might have this spleen peeking through in there as well, but it wasn't labeled, so we're not too sure.
Yeah, so this is why labeling is helpful, just so we know kind of where you're at, but trying to piece this together. Looks like the spleen is here. It just doesn't, normally we start with the right upper quadrant in a FAST just because it's the most sensitive area. But it looks like this is a left upper quadrant view, and I can also see parts of the stomach here that are probably being well transmitted because of all this fluid that's here. So you see the stomach kind of peeking in around the 6 o'clock position of the view. And this just has an appearance of a spleen rather than a liver. So what's abnormal about this? Sort of already mentioned, but
Yeah, it looks like there's some free fluid there.
yeah. So lots of free fluid, subdiaphragmatic, surrounding the spleen. So let's look for other views within the pelvis and see if we can piece this together. So now, this one's not labeled either, but they went down towards the pelvis because during the workup, her pregnancy test was positive. So now they're looking at the pelvis. And this is actually a view of the right side, not midline. And what are they noting here, Emma?
Yeah, so it looks like there's some cystic structures or cystic components perhaps to another structure, and then just some irregular large mass of some sort on that right adnexa.
Right. So this is a pretty big mass, about 8 centimeters, I guess, based on if we kind of use our depth markers as a gauge. Mixed cystic components, right? Like cystic up at the top part with some mixed solid component as well. Fan through here. So these are either like multiple cysts or loculation, there's septations between them. Just like not a normal structure that you normally see in the right side of the abdomen. So she's pregnant, she's got severe abdominal pain, she's got syncope, she's got hemoperitoneum in the left upper quadrant. What are you concerned for?
Most concerned for ruptured ectopic pregnancy.
Yeah, absolutely. So especially with this abnormal mass here, right?
Absolutely.
And then now they're going into the right upper quadrant because we see what appears to be the liver here. You can see a little bit of the right kidney as well down in this portion of the clip. And then we see some anechoic area between the liver and the right kidney. Frankly, I'm not sure if this is free fluid or this could be the gallbladder. That's one of the common pitfalls is like people mistake the gallbladder for fluid because it's kind of in the same location. It could be, I'd like to see a little bit more scanning through this area to be able to help me differentiate between. But the point's kind of moot right now, right? Because we know in the left upper quadrant there's a lot of free fluid that's confirmed. Usually the right upper quadrant is the most sensitive area to find free fluid, but sometimes if the patient's been laying left lateral decubitus for a while, sometimes that fluid can shift around. So that's why it's just important to look for all your views of your FAST. So this patient was diagnosed with a confirmed ruptured ectopic pregnancy. She went to the OR. She got transfused multiple units and had a hemoperitoneum of 800 milliliters. So just good teaching points for this one. Like you said, syncope plus abdominal pain and a positive pregnancy test is ectopic pregnancy until proven otherwise. The right upper quadrant is typically a more sensitive area, but look all throughout your FAST and try to label your views just for clarity with review and when speaking to consultants. Next patient came in with right upper quadrant pain, and they did a gallbladder ultrasound. So Amelia, can you walk us through some of the findings here that they're seeing in the gallbladder ultrasound?
Yeah, so there are a couple of things to point out here. We can certainly see the gallbladder, but on certain views of this gallbladder, you see this hyperechoic kind of stripe in the gallbladder with some posterior shadowing, which is pretty suggestive of a gallstone here.
Right. So I'll pause here. Some of the stones. Stones are hyperechoic, right? Because they're usually calcified and reflect all the sound waves off, appear very bright, and then have this posterior shadowing. See one there, another one here. And then I'll let the clip play again. What else about the gallbladder, the internal components of the gallbladder, do you notice?
Yeah, so inside of a gallbladder, we would expect to see more of an anechoic texture to the gallbladder, but here we see this like mixed echo texture within the gallbladder, which is also pretty suggestive of sludge.
So then they're going to go ahead and measure the wall. So they're measuring the anterior gallbladder wall here. And we talked last month about how we usually measure the anterior wall instead of the posterior wall because of this artifact called posterior acoustic shadowing with a sound waves going through a fluid-filled structure. So you notice here that this posterior wall looks very bright and very thickened So if you were to measure this, you'd get a very artificially large wall because of this artifact called posterior acoustic enhancement. But they're going to measure this anterior wall. So how do you interpret their measurement of 0.57 centimeters, Amelia?
Yeah, so it's a little bit thickened. For a normal gallbladder wall, we would expect it to be about 3 millimeters or less.
Right. So this is indicative of gallbladder wall edema or gallbladder wall thickening. And now we're going to go through a longitudinal view and redemonstrate that sludge and stones here in this view too. You notice that on some of the views, you see the gallbladder has this fold in it. See here, it comes down and it's got like a bend, or it's called a Phrygian cap. It's just a kind of an incidental normal variant finding, but not to be confused with any pathology. But this patient definitely does have pathology. So can you kind of summarize the findings of cholecystitis we have here, Amelia?
Yeah, so it looks like we have some gallstones with associated sludge.
Have you ever heard of the sign called the sonographic Murphy sign?
So like your traditional Murphy sign when you're pushing on someone's right upper quadrant, when you're doing the same with the ultrasound probe, and patients will feel discomfort with the probe when they're looking at the gallbladder, which is consistent with the sonographic Murphy sign.
Right. Rather than that kind of cessation of inspiration you normally get with the traditional Murphy sign. It's kind of, you're pressing, looking at the gallbladder directly, and you're pressing into it, and eliciting tenderness over that area, sonographic Murphy sign. So we have gallstones, gallbladder wall thickening, pericholecystic fluid is one of the other features sometimes you can see. And then I'm not entirely sure, it could be some pericholecystic fluid here, a little bit of anechoic stuff along the gallbladder wall right here next to the liver. But she's definitely got enough features that I'd be convinced for cholecystitis in this case. So she was diagnosed with cholecystitis at the bedside. So this next case was a 60-year-old woman who came in with respiratory distress. And as part of her workup, she ended up getting some aorta scans here. So we're going to go through an aorta scan. So Amelia, how do you usually identify the aorta? There's a lot of vessels here. How do we determine which one's the aorta, and what sort of landmarks do you typically use?
Yeah, so you know that the aorta is going to be anterior to the spine, so you can look for the spine sign to confirm that the vessel you're looking at is indeed the aorta.
Right, so in here, I think this is the spine. You see the hyperechoic line here. So this is reflective of the vertebral body with posterior shadowing behind it. And then typically you'll have two vessels that are just anterior to that. And if the sonographer has the probe in the correct orientation, this is the patient's right over here, and the patient's left over here. So up towards the patient's left, or the screen right, will be your aorta. And then towards the screen left will be the IVC, typically. So let's focus our attention on the aorta. And do you see anything abnormal within the aorta here?
Looks like there's a hyperechoic line that's in the middle of the aorta, potentially a dissection flap. It looks like it's pretty mobile with every pulsation of the aorta.
Right. Yeah, so with each heartbeat, that flap is going to undulate a little bit, and that's one of the reasons why you would need to make sure that you have good heart rate control for the patient, right? Because each time the heart beats, it's potentially further extending that dissection flap. So if we were to measure the aorta, though, it grossly looks normal, but they didn't measure it. Do you think that there's associated aneurysm with it? Or how do you typically do a measurement?
Grossly, it appears normal, but we can measure it from top to bottom, anterior to posterior.
Yeah, let's just do a measurement here. So we usually would do it at end diastole is typically, and we would do a measure from the outer part of the wall to the other outer part of the wall. So, just around 3 centimeters, which is kind of top normal. So, she does have definitely a dissection flap there. So let's keep going. Now let's look at a longitudinal. This view is okay, but I think they got a little bit better view next. Perfect, yeah. So now you can see a little bit better aortic anatomy. So Emma, what are some of the branches you're seeing here? So like this up here near the heart, so this patient's head and towards the feet, you see some branching coming off.
Yeah, so that first branch that's coming off is your celiac trunk, and then that next branch is your superior mesenteric artery, and that'll kind of curve around and run parallel to your aorta.
Right. So it comes off kind of a 90-degree angle, then we'll go down and follow it parallel to the axis of the aorta. And then usually I have the inferior mesenteric artery after that, but it's a lot of times hard to see on ultrasound. So let's play the clip again and look at the aorta lumen. And you can see that dissection flap again, right?
Yeah.
Yeah. So it seems to be moving with each heartbeat as well. So then they're going to go over towards, here's another view. They're going to go do the heart. So why do you think that they're doing an echo in this situation?
So I think sometimes if the dissection flap expands enough, it can interfere with the aortic valve and cause some aortic regurgitation. So my guess is that's probably what they're looking for here.
Yeah, they can do that. And then there's also sometimes the dissection can dissect backwards into the pericardium and actually cause cardiac tamponade. So in this situation or this scenario, we don't see any significant effusion, right? We have the descending thoracic aorta here. It's not super well seen, right? But there's probably like a little bit of a dissection flap right there, because on this patient's CTA, they had a type A dissection, meaning that it came off around the aortic arch and kind of extended all the way down towards the abdomen. So this is the thoracic aorta, and there's probably a dissection flap in there. It's just not super clear right here. But I don't see any significant pericardial effusion that would be concerning for developing tamponade.
Got it.
So other ways in general that sometimes people can get confused between the IVC and the aorta when they're scanning. They did a good job of recognizing the IVC here. But generally the IVC is going to be more thin-walled, can sometimes be compressible if you use enough pressure, and is towards the right of midline versus the aorta, which is going to be more thick-walled, will be pulsatile, not going to be compressible, and it's the left of midline. All right, and our last case for this month is a 30-year-old man who came to the ER with dizziness and chest pain and shortness of breath. He was a dialysis patient with blood pressures of the 230s over 140s. And as part of his ED course, he ended up getting a panel of ultrasounds. So we're starting here with a fast exam. So Amelia, what are your thoughts about this right upper quadrant?
So we can see the liver and we can see the right kidney as well, but there are a lot of these anechoic circular structures consistent with too many cysts to count on this kidney. Yeah, so
In the area where the kidney should be, right? But we're not seeing really any normal kidney architecture. You usually see the nice differentiation between the cortex and the medulla, but you just have too many cysts to count. So polycysts, you may have polycystic kidney disease. So this is probably why he ended up on dialysis in the first place, right? Because the normal kidney architecture and the nephrons are sort of crowded out by all these cysts and developed all these complications from it. So what other complications can you get and associations with polycystic kidney disease?
You unfortunately can get berry aneurysms.
Yeah. Yep. What else, Emma? You can get cysts elsewhere in the body?
Yeah, you can get cysts in your liver. I think there's also increased risk of diverticulosis.
Mm-hmm. And there's some increased risk for cysts in the spleen and the pancreas as well. So basically just cysts everywhere, and just remembering the berry aneurysm risk too. So this patient, just clinically, this was already known, but I just thought it had really interesting findings here of this polycystic kidney disease. So in his case, he was hyperkalemic to 7.3 with some EKG changes, required emergency dialysis, but ultimately did well. All right, great job, Amelia and Emma. Those were some really cool cases, and I appreciate you sharing all those teaching pearls. I was just going to upload a quick summary of the cases we discussed For case 1 with pregnancy, it's really important that you don't diagnose pregnancy until you see a yolk sac. That's the earliest finding of an intrauterine pregnancy. And we're using that primarily to rule out ectopic pregnancy. For the second case, always remember abdominal pain plus syncope plus a positive pregnancy test equals ruptured ectopic pregnancy until proven otherwise. For the third case, for our gallbladder, you can look for stones, sludge, and the sonographic Murphy sign. Those all point towards acute cholecystitis. For aorta scan, dissection flap can be seen as this oscillating echogenic line. If you see that and it moves with each heartbeat, I would be concerned for dissection. And lastly, polycystic kidney disease can cause some striking images with these massively enlarged cystic kidneys, and remember that it can be linked with some other important systemic complications. All right, so let's move into the listener Q&A section. We have here a question from Dr. Okafor, who is one of our emergency medicine residents, about ultrasound IVs. Let's take a listen.
Hey, Dr. Watson, it's Christy, one of the PGY2s. The other day, I was just realizing I'm always having a hard time following my needle tip when I'm doing ultrasound-guided IVs. Do you have any tips for me for getting better at those? Thanks.
That's a really great question, Christy. Ultrasound-guided IV is super helpful in the emergency department, and we're often called on to place difficult IVs, and using ultrasound is super helpful. But it's really important to be able to follow your needle tip, and there's some other skills that are really important in incorporating this into your practice. To help answer this question, I'm going to bring in Dr. Yasmina Abdous, who is one of our excellent emergency medicine residents, and is going to walk the listeners through how to place an ultrasound-guided IV. Yasmina, really happy that you're here. Thanks for being here.
Happy to be here.
So Yasmina, can you start off by walking us through what equipment you'll need to make this a successful procedure?
Of course. So with any procedure, having all your equipment at bedside is the first step to success. In terms of things you'll need for an ultrasound-guided IV, you will, of course, need some ultrasound gel, as well as some sterile gel. For the actual IV itself, having a long 18 gauge or 20 gauge IV as your two options, having a J loop, a flush, a tegaderm for your IV, as well as a tegaderm for your ultrasound probe. And then, of course, things to prep and clean the area, like a core prep.
So that's great. So now you have all your supplies together. How do you prepare the patient and prepare your probe?
Get your patient in the right position, put your tourniquet on. You're going to use the linear probe, which is the high frequency probe, using your unsterile gel. Put some gel on the probe, and then get a tegaderm, put it on top of that probe, and kind of press out all the air bubbles. And so now you have a sterile probe cover, and you can use sterile gel to then look for your veins. And so you can kind of prep the whole arm, looking at a few points that are good targets, the AC, so you can get the cubital vein, or you could go in the inner arm and get the basilic vein. You could also look a little further down if there's no good targets up there.
So how do you tell the difference when you're looking through what's an artery and what's a vein?
The big thing is going to be compressibility. And so being comfortable with having light pressure while using the probe to be even able to see those veins, and then kind of compressing them down. They should be fully collapsible, versus an artery would be a lot thicker, pulsating, and wouldn't collapse as easily.
All right, Yasmina, so next, just walk everybody through how you go about actually inserting the IV now.
You'll first hold the probe with your non-dominant hand. Hold the catheter and the needle with your dominant hand. You'll hold the needle like at a 30, 45 degree angle. You'll have it kind of positioned right where that tick mark is on the probe, so that you're right in the middle of the screen, about half a centimeter away from the actual probe. When you're set up and you're holding the probe with your non-dominant hand, it's very important to try to anchor using your pinky or ring finger to hold on to the patient a bit, so that you're not moving as much when you're actually trying to visualize the needle. And everything is small movements. Probe moves once, needle moves once. And so once you break through the skin with the needle and you can see the tip of the catheter on the screen, then you move your probe away from you. And then continue those small movements until you actually see the tip of the needle inside the vein.
Then once you do see the needle tip inside the vein, what's the next step and how do you actually thread the catheter?
So once you see the tip of the needle inside your vein, that's the point in which you want to flatten out so that you can push more of the needle into the vein and then thread the catheter over it.
So this technique that you're describing, is this called the in-plane technique or is this the out-of-plane?
So this is the out of plane technique. And so you're only seeing that needle tip as you're moving through the process. You can also do this in plane where you can actually see the entire needle breaking through and going into the vein.
Yeah, I find that with that in-plane technique, it can be difficult because just slight movement side to side makes you lose your entire needle tip. But you do need to be careful with the out-of-plane technique that you're following the needle tip. And that's why we're walking down in this stepwise fashion, and that we don't want to accidentally mistake the shaft of the needle for the needle tip. So we're always making the needle tip disappear on our screen and then reappear, just so we know that we're just following the very distal end of the needle tip. So commonly we have issues with IV access in pediatric patients. Do you have any tips for success with pediatrics?
Sure. So, big tip is always have a distraction, keeping them calm, right? So they're always moving around. The next thing you could do is also warm the extremity prior to looking for that vein that you're going to go for. And then the third tip, we think about it with adults, but you have to think about it a little bit more with kids, is just to not put as much pressure with the probe, and so that you're actually able to see those veins that you're going for. And then, if necessary, using some sort of topical anesthetic.
Awesome job, Yasmina. Thank you so much for sharing those pearls. To wrap it up, ultrasound-guided IVs come down to three things: preparation, visualization, and control. Start by gathering all your supplies and prepping your linear probe with a sterile tegaderm so you're ready before you touch the patient. Identify a compressible vein. Somewhere in the arms, can be the forearm, the AC fossa, or the basilic area in the inner biceps, by using light pressure and confirming it collapses. Use the out-of-plane technique to track your needle tip. Move the probe forward, then advance your needle tip and see the needle tip show up right in the center of your screen. Move the probe a little bit and make it disappear, and then keep having your needle tip reappear on the screen so you know you're following just the needle tip. Once you see the tip in the vein, then you're going to flatten your angle and thread the catheter. Small movements, gentle pressure, and constant needle tip confirmation are the keys to success. With practice, this becomes one of the most reliable and satisfying procedures in the emergency department. All right, so that brings us to the end of the December 2025 episode. I hope you enjoyed all those cases we went through and that awesome tutorial that Yasmina Abdous gave us for ultrasound-guided IV. Remember, if you want to leave a question to be answered by one of our experts here on the podcast, you can submit it at speakpipe.com/soundcheck. We'll be back next year with some new cases in January 2026. So until then, go out and put these pearls into practice.